Dobbiamo fare. Okay, so here we are. This is a lecture I had the opportunity to present at the Congress of the European Academy of Orofacial Pain and Dysfunction concerning TMJ imaging. And the basic point was, I got imaging, I got the criteria, I got the standard of reference, whatever you want, but when does the prescription of an instrumental assessment is significantly affect the treatment plan? So the concept of effective prescription, in my mind, is the real needed criterion to evaluate the need for an imaging prescription in this case, but it could be extended to all other instruments in the field of dentistry. And I love citing this paper concerning the efficacy of diagnostic imaging in particular. But if you think about the hierarchical evaluation of the effective prescription, you can easily understand that those 6 levels proposed by the authors to evaluate the efficacy of diagnostic prescription can be applied to many fields of temporomandibular disorder practice. Basically, what the authors said, they said that we need 6 levels of hierarchical efficacy, starting from technical efficacy, which is the basic requisites. So the quality of the images in this case should be technically acceptable. Then we must have diagnostic accuracy efficacy, which means that the capability of the instrument to discriminate between patients and non-patients is acceptable. So basically the results of the instrument gives me an idea about the condition of the patient. Am I dealing with a person who needs for treatment, or am I looking at an MRI of a patient walking around Marina di Carrara? Then, if the diagnostic accuracy efficacy is satisfied as a criterion, the third step is to think about the diagnostic thinking efficacy. So, is the information gained with this imaging technique really changing my diagnosis? Think about what I have said some minutes ago. Pain with the palpation, presence or absence of intra-articular fluid, okay? If I don't see any intra-articular fluid, my diagnostic thinking is changed, because of course I could start to suspect the presence of some non-articular condition mimicking pain there for some reasons. And if I satisfy this criterion, then I should move to the therapeutic condition. So my prescription could be efficacious from a therapeutic viewpoint. So it helps me changing my treatment plan. No inflammation there, so maybe no appliance, no arthrocentesis, or whatever you want. And sometimes, if I have been able to change my treatment plan thanks to the prescription of that imaging, I could be also able to change the patient outcome. So this is a way of reasoning which is, in my mind, fundamental to discriminate, and don't forget the social efficacy, okay, in terms of cost effectiveness and that kind of stuff. But in my mind, this is a way of reasoning which is really fundamental to discriminate between things that may be useful for our patients and things that are fake progress. With fake progress, I mean that it is something that it's being just introduced in the market, but it doesn't give real information to provide a better treatment to our patient. And I remember some years ago, we were in Scottsdale with all the orofacial pain community. And once again, I was there to give a disturbing lecture on the potential use of diagnostic technology. And the camelback, this was my little one, 1 year old at the time, playing golf, okay? And my main message at that time was that based on the hierarchy of effective prescription, all these fancy technologies are not useful because they have no relation with pain and function. They give up to 100% of high false positives. They may be used to overtreat patient via dental occlusion. So at best, they reach the level 1. They are technically nice, okay? But they have no usefulness to diagnose orofacial pain. So the step 2 and so on are not satisfied. Concerning imaging, which is the topic of this lecture, the same reasoning should be applied. So technical quality, of course, is there. Please forget simple tomography, for instance, okay? It adds nothing to your practice. It's just another dose of X-rays to your patient. But anyway, the technical efficacy of the imaging is there. Look at this wonderful reconstruction. But do I need to expose the patient to this dose of radiation just to look at the condyles? You know the answer. You know the answer. I will never perform a CBCT just to have this 3D reconstruction to my daughter. Technically, we must know that concerning magnetic resonance imaging, which is the standard of reference for temporomandibular joint disorders evaluation purposes in the field of imaging, we must know that there are different parameters of the magnetic field which are differently suitable to evaluate the soft tissues anatomy or the presence of pathological fluids. So basically, the more the magnetic field is enhanced and the cellular nuclei are excited by this magnetic field, the more you may be able to evaluate the presence of inflammatory fluids, and you lose details on the soft tissue anatomy. So basically with T2, the disposition is not really easy to visualize, and with T1, you cannot visualize at all the presence of inflammatory fluid. We'll have the entire afternoon to get deeper into this detail. So concerning imaging, the bottom line is that technical efficacy is there to see. This is basically a textbook of the temporomandibular joint. You can see easily, even if you are not an expert, the condyle, the ear, the mandible, the mandibular angle, the disposition, and the change in terms of this to condyle relation between the closed mouth and the open mouth position, with the disc shifting from the 12 o'clock at the posterior band to the 12 o'clock at the intermediate band position with respect to the condyle. So for sure, a level 1 in the field of magnetic resonance is easily achieved. Level 2, which is the diagnostic accuracy efficacy, means that my imaging, in this case, should be able to correctly identify most of the cases, which means, who are the cases? The cases are the patients, and patients come to your office because of one reason. That reason should be visualized via imaging. That population of patients with that specific clinical complaint, which is the reasons for them to come to your attention, can be discriminated via imaging from healthy individuals. That's the main point, okay?